All right, so for the second half of this video, we have spoken about the myeloid neoplasms. So now what we'll be speaking about is the lymphoid neoplasms. So lymphoid neoplasms can be divided into non-Hodgkin lymphomas and Hodgkin lymphomas. Now, non-Hodgkin is the more common one, about in 60% of the cases. And you might wonder, okay, what is the difference between these two, right? Already myeloid leukemias are kind of complicated. So what's the deal with lymphoid neoplasms? So again, lymphoid neoplasms are arising from lymphoid tissue or exolymphoid or non-lymphoid tissues. For example, if you consider the GIT, but they have aggregates or they have follicles, lymphoid follicles, or aggregates of B cells with germinal center, etc. So it can arise over there as well. Now, um, one of the main things is that in non-Hodgkin lymphomas, okay, most of the neoplastic cells are B cells. Okay, some T cells might be involved. Okay, and in the background, there can be a low number of non-neoplastic cells. What does it mean? Well, in the background, I mean other leukocytes. For example, it could be neutrophils, basophils, eosinophils, etc. But there will be many tumor cells. Now, these tumor cells again are B cells most of the time. In Hodgkin lymphoma, there's something known as Reed-Sternberg cells, which is quite characteristic. Now, these are basically, you have B cells from the germinal center of these follicles, okay, lymphoid follicles. They are going to merge together and they are going to form these neoplastic giant cells. They're going to be giant, they're going to be huge, okay? And what they're going to do is they are going to release cytokines, which is going to stimulate uh, the proliferation and the accumulation of other inflammatory cells. So basically, there'll be a lot of background cells, that is neutrophils, macrophages, basophils, etc. All right. So that is the difference. To conclude, non-Hodgkin, you're going to have a low number of non-neoplastic cells in the background, whereas in Hodgkin's, there's going to be a high amount, and there'll be relatively sparse Reed-Sternberg cells, fewer amount of Reed-Sternberg cells in a large amount of background cells. Now, if you ever get confused between the two, just remember that Hodgkin doesn't have the word non, so it contains Reed-Sternberg cells. I don't know if you can make that relation, but that's how I remember it. Non means no Reed-Sternberg. If there is no non, then it's just Reed-Sternberg. And if there's Reed-Sternberg, which it means it's going to activate and create the accumulation of other inflammatory cells, which means a lot of background cells are going to be there. And that's the opposite in non-Hodgkin. Okay. Now, other differences include the following. So in Hodgkin's lymphoma, the affected nodes are usually localized. They're single group of lymph nodes, for example, just the axillary uh, or just the supraclavicular. And maybe there can be some spread, but if it spreads, it means that it's a pretty serious stage, you know. But overall, the prognosis is better than that of non-Hodgkin lymphoma. Whereas in non-Hodgkin lymphoma itself, multiple lymph nodes throughout the body can be involved. And it can also be extranodal involvement, which means it can also affect the GIT lymphoid follicles or the pharyngeal lymphoid follicles. And they have a non-contiguous spread, which means that, let's say, for example, they start in the supraclavicular nodes. It need not uh so it need not be the case that from supraclavicular it's going to go to a specific lymph node around it and then it's going to further go in that direction to the rest of the body. Some of the neoplasm can start in the supraclavicular. All of a sudden you'll find the tumor present in some other group of lymph nodes, which is quite far away from the origin, you know. So here it is non-contiguous and extranodal involvement is common. Now, in non-Hodgkin, there's going to be, and both even in Hodgkin as well, there's something known as the constitutional B signs or B symptoms. So this is basically very important. You have to know that it's a combination of low-grade fever, night sweat, and weight loss. Okay, so these three are very important. Now, um, another thing is non-Hodgkin's can occur mostly in children and in adults as well. Um, and they are associated with HIV and autoimmune diseases, whereas Hodgkin's has a bimodal distribution. That is, it's either going to affect someone who's more than 55 years old or someone who's very young, you know. And this is associated with EBV, Epstein-Barr virus. Right. Also, Epstein-Barr virus is going to, I think, trigger NF-kappa B or NFKB pathway, and that's going to create or that's going to cause these B cells to sort of fuse together and become a neoplastic giant Reed-Sternberg cells. Okay, so that's also another way you remember that is associated with EBV. Right. Now, under non-Hodgkin, we have got, uh, of course, most of them are either B cell or they could have some T cell neoplasms, right? Now, these neoplasms can either be related to precursor B cells, that is, non-mature B cells, or it could be mature B cells. Now, mature B cells are typically already present in the periphery, right? Whereas precursor are usually associated mainly in the bone marrow, or they can get spread into the blood. So for precursor, you have acute lymphoblastic leukemia or acute lymphoblastic lymphoma as well of pre-B lymphocytes. Under mature, you can have small sized, intermediate, and large sized. Again, I'm not going to go into depth with this because there's a lot of things to cover regarding each one of these, and it's there in the organ systems. Similar to B cell, precursor and mature, you have the same thing with T cells. So here you have acute lymphoblastic leukemia, and here also you have acute lymphoblastic leukemia, but of pre-T lymphocytes. Okay. And if I'm not wrong, I think the T lymphocytes are mostly associated with acute lymphoblastic lymphoma because they are going to affect the nodes, the lymph nodes as well. There's a higher tendency for the T cell neoplasm to affect these lymph nodes, and therefore you could call it a lymphoma. Um, Now, other than this, you also have NK cell neoplasms, and under this, you can have mycosis fungoides and Sézary syndrome. This is quite important. I think you will definitely come across this in the organ systems. And coming to Hodgkin's, there is you have to know each one of these. So here, there's a WHO classification. There's 5 classical and 1 non-classical. And again, remember, Hodgkin, Reed-Sternberg. How is Reed-Sternberg created? NFKB pathway. What triggers NFKB pathway? Most probably Epstein-Barr virus, right? So this is associated with Epstein-Barr. Now, you have 4 classical ones. That is going to be nodular sclerosis, mixed cellularity, Hodgkin's lymphoma, lymphocyte-rich, lymphocyte depletion, and they mean exactly what they say. There's a large amount of lymphocytes. There's depletion of lymphocytes. And then the non-classical one is lymphocyte predominance. Now, I've highlighted these and I've also underlined these, and you can differentiate between the facts. For example, here you have it seen mostly in adolescent or young adults, whereas mixed cellularity is mostly common in patients older than 50 years. Lymphocyte rich is again older adult males than females. Lymphocyte depletion when more than 50 years of age. And this is important. There's one peak in children, and the other one will be usually at 30, 40 years of age. That's one important point for differentiation between the two. The second important point is to understand whether they're associated with EBV or not. So, for example, nodular sclerosis may or may not be associated. Mixed cellularity, mostly associated with EBV and also common HIV. Lymphocyte rich, 40% association, depletion, a large amount of association, right? And here there's no association, okay? Then you can understand how aggressive it can be. So nodular sclerosis is the most common subtype. Mixed cellularity is the second most common subtype. Rich is uncommon. Lymphocyte depletion is least common. So you can look at it as most, second most, uncommon, least common. And over here, it's variable. Yeah. Then you have histiocytic and dendritic cell neoplasms, apart from lymphoid and myeloid. Now, this again is covered in proper detail in organ systems. Just read that. or go to the videos that we will be making on that and literally see the same thing over here. There's no need to cover so much information in this small question. Now, some symptoms are very important. If at all they ask you about, okay, the difference between a lymphadenopathy in lymphoma or let's say a lymphadenopathy caused due to some infection. What is the difference? Tumors are usually they're not painful. Okay, so there's painless lymphadenopathy, whereas an infection caused lymphadenopathy uh, or lymphadenitis is painful. Okay, that's very important. Remember that. Now, again, in lymphomas, usually they infiltrate organs. Like I mentioned, they can have nodal and extranodal tissues infiltration. There's often hepatosplenomegaly, and there will be bone marrow involvement as well, because it's again lymphocytes are also like created by bone marrow, right? That's where, and then they go into the primary lymphoid organs and secondary lymphoid organs, and then they get differentiated. But bone marrow involvement can be there, and even they can get into the leukemic stage where they'll affect the blood as well. In leukemia, there's often fatigue, there's immunosuppression. Definitely, they'll be more susceptible to infections and fevers because they can be cytopenias. Again, it's more functional and morphological, but there'll be a huge increase in the number of blasts, and that's what constitutes the neoplasm. Okay. Um, there can be hemorrhagic diathesis, that is bleeding tendencies, nosebleed, ecchymosis. Again, this can be because of improper formation of thrombocytes, because you'll have an increase in number of thrombocytes, but they are dysregulated and they have a variable functioning capability, you know. Of course, bone pain because the marrow can like sort of enlarge because there'll be a huge production of cells, there'll be a huge turnover. They can also undergo fibrosis, which is more or less the, I would say, basis of primary myelo or essential myelofibrosis. Um, and then there can be hepatosplenomegaly. It's the same for lymphoma and leukemias. And they can also affect the brain in acute lymphoblastic leukemias, at least. Now, macroscopic features, right? So, lymph nodes enlarged, bone marrow enlarged, then they can get atrophied. There can be yellowish or gray infiltration and activation of reserve zones. Reserve zones are basically these zones where you have all these blasts and pluripotent stem cells, etc. And then, of course, hematopoietic I can't say this word. Histogomologous organs. It means hepatosplenomegaly, etc. And other organs, for example, GIT, pharyngeal mucosa, liver, what else? Lungs, of course, definitely lungs, trachea, they can all have these infiltrations. Pleural cavity, also pretty important. Now, um, other general histological, this is microscopic features, lymph nodes, there's going to be definitely a change in the shape of these lymph nodes. There's going to be a change in architecture. There can be nodular or diffuse lymph node histological changes. That is, you could have either specific nodes and specific parts of nodes enlarging, or you could have a diffuse enlargement of the nodes or diffuse number of nodes being enlarged. Transcapsular spread, that is the spread through the capsule and to the surrounding tissues. Bone marrow can be hypercellular. It can be cytopenic. Again, not all cases. Again, cytopenia means you have a lot of cells being produced, but they're not functionally mature and they're not morphologically mature. So you have a cytopenia of the mature cells, if you know what I mean. Like proper functioning erythrocytes are low in number. Again, architecture can be changed. Um, and then also another thing is, so usually you have fat in the bone marrow, and within them there can be some hematopoietic cells, and there can also be a hematopoietic activation of of this fat that is present in the bone marrow. Again, histohomologous. Oh, it's histohomologous. Okay, why was it? Okay, histohomologous organs. This is spelling wrong. Yeah, histohomologous. That's where I was wrong. Okay, histohomologous organs, liver, spleen, nodes. Now, something interesting is in Hodgkin's lymphoma, you have these constitutional symptoms. There's often itching, it's also known as pruritus. There's something known as a Pell-Epstein fever. It's an uncommon fever variant. There's alternative bouts of fever followed by remission. Again, Hodgkin's lymphoma, if you go up this document, Hodgkin's, single group of nodes, right? And contiguous spread. They're usually localized. So if you look at this, painless, localized lymphadenopathy, okay? And also an interesting fact, chest pain, cough, dyspnea, like I mentioned, pleural cavity, lungs, trachea, very important because you have parabronchial, mediastinal lymph nodes, um, etc., right? And of course, they all have increased risk of developing AML, acute myeloid leukemia. What is it? More than 20% blast. 20%, I mean, out of 100% of the population of these leukocytes, both mature and immature, 20% of that population is occupied by blasts. That's a huge number. So that's the situation. So yeah, just to summarize, just know that you have to go through the organ system questions, say this, literally choose what you want to say, but have a basic structure, like basic introduction, differences, signs and symptoms, brief explanation of the subtypes, and you're done for this question. Okay, anything extra, mention it if you get the organ specific question. Whether it specifically ask you about Hodgkin's lymphomas, non-Hodgkin's lymphomas, etc. All the best. Thank you.